sports related to that, and then we have also sports surgeon and Dr. Wright. And then we have this new partner, Dr. Kimbo. He's almost more than a year now, because he was coming for a locum and we really loved him. And we are so lucky to have him.
Oh, great.
So I think he's also helping us out. He's a joint replacement 2 fellowship trained like me.
And what's his name again?
Dr. Kimbo.
Dr. Kimbo.
So I think that's good. So we are 4 orthopedic surgeons, and that's traditionally we used to have 4, and we are maintaining that as a group, which is a good sized group. And services wise, in almost we cater to almost 50 counties. We get patients from all northwest Kansas.
Really?
Yes.
Oh my.
And especially that turns out important when we provide 24/7 coverage. Even in the time of in the winter season and holiday season, then our coverage is even more important, because some of our friends in the other cities are off or they take vacation, and then the coverage is not available. Then we provide that coverage for all those patients. So we get a patient from really far off areas sometimes.
So the Hays Orthopedic Institute serves a broad area then.
Exactly, area-wise and as well as services-wise. And then with our ancillary support staff, for example, our cardiology program is exemplary, and our general surgeons and trauma program, we are level 3 trauma center, which is, and so that also helps with all those ancillary services. We have a pulmonologist available and ICU services, so all those patients, and that's generally our treatment patients. We get a lot of referred patients who are have significant medical problems, are not that good, and they need orthopedic surgery. So that's make us more challenging, but that's what we like it.
So the pulmonary service is one of the ancillary areas then of the Hays Orthopedic Institute. Now, your mission will be to visit with Dr. Kimball and say he's been there a year, he's settled in, it's time to get on the radio.
Okay, I will talk to him about
about that and use your influence now. It's been 6 years since you've been here. Almost 7.
7 years.
7 years now.
7 years.
Wow.
So I'm the most senior partner now. So
that's
I like
great.
it.
You get the privileges, don't you? You get the special treatment and such.
I think I feel more of honored in a sense, and I like it when people recognize you in the community and you go to the other places. I grew up in the same kind of environment back home, so I feel comfortable and happy that people recognize you and you recognize them, and meet sometime outside your practice, and that's really, you see, smile and you say how you're doing, they say, yeah, we're doing good. It just feels good.
Thanks to you, we're doing well. Absolutely. Dr. Cheema is also very interested in foot care, so be sure and call if you have any foot care questions that you want to ask Dr. Cheema about. But he also does hand surgery, and that's where we want to start this morning, because there were a couple of folks who have had a surgery on carpal tunnel syndrome, and they are doing extremely well. But 2 people of our association area within the last, couple of months, I suppose, carpal tunnel syndrome. How does it happen? Why does it happen? And what goes on here?
I think it's a good question. The first thing is that carpal tunnel sometime related to your professional work, what kind of work you do. For example, people working on the keyboard all the time, and musicians like playing guitar and all those instruments like piano.
Carpenters using hammers and stuff like that.
Yes, exactly. And and the other thing is sometimes pre-existing conditions. For example, if somebody is diabetic and has diabetic neuropathy starts with, but also has carpal tunnel, but overall they have increased chances, and some patients get sometime with certain medications because of there's thickening of the carpal tunnel or the structures in the carpal tunnel. So carpal tunnel is like where the tendons are, where the nerves are, and so it has limited space. Whenever there's increase in volume of that carpal tunnel, that can cause a pressure, because the carpal tunnel is surrounded by the ligament on the top between in the palm. That's what called transverse carpal ligament. So that's pretty stiff structure, so it doesn't give away. And so what it causes, like with the pressure and the way we work, the nerve get under pressure.
Because it's actually on the I guess you'd call it the underside if you're working with your hands.
Yes.
It's on the underside, so it gets all the pressure all the time.
Yes, all the time. And then again, with the motion and the kind of work we do, especially with the keyboard, it get affected. So there are different kind of symptoms can happen. Some people can feel like shooting pain and burning, and especially at night, they wake up.
Oh.
And some people get over time numbness and tingling, and sometimes even this so long, they're just numb all the time.
Oh, wow.
And that's what I explain to my patients, that you should not wait too long for the symptoms to happen, because the reason is if that nerve is under pressure, and when we do, we usually try to do the testing. That's our protocol. Some studies, they're available, you do it do the surgery clinically, but I still feel it's good to have on the back of the studies. Nerve conduction and EMG studies, where we have our bottom Dr. Casso, he comes from Salon, and we have a clinic in Hays, so patient don't have to go anywhere.
And did one with him, as a matter of fact, when I had some issues.
Yes, and then he also goes to, I think he started going to Great Bend too, so that will help to patients over there. And that just shows what kind of damage it is. Sometimes even patient has a carpal tunnel syndrome, and the nerve conduction studies are normal. And in that scenario, it is probably better, because it means their nerve has not damaged yet to the extent that it's identifiable on those testing. On the other hand, they can see that I don't have that problem, but usually if clinically they have the problem, it means they are having the symptom, but nerve has not damaged enough.
Just because that test does not relate to a damage shown
at this
doesn't
time
mean that you shouldn't take care of it.
Exactly. And then the second, then if it shows damage, then it shows what kind of damage is usually. Like if it's less damage or more, if it says axonal damage, which is the main nerve itself, and it's extensive damage, then the recovery is slow and unpredictable. That's what I tell all my patients, that the carpal tunnel surgery, we don't do usually anything with the nerve. We just take the pressure off and let it heal. What happens? It just depends.
And sometimes it heals properly, sometimes it doesn't.
Exactly. And I have seen my patients which has noticed a difference in recovery even within hours. Some people notice a difference when we see them the first post-op visit, usually 2 weeks. And some people has noticed difference 6 weeks, sometimes it's longer. And some people have really, even in a year, feel a little bit of difference, maybe not. That's why it depends if you intervene early and does not get it damaged. Surgery is relatively simple, because just we take the pressure off and release that. Every surgery has its own chances of complications, but usually they are low. And so that's, I think, a lot of people, and it's sometimes riskier, because I have seen a few of my patients, they say they can drop the things. And the other thing, sometimes if their sensations are gone so bad, they cannot feel it. I'm just coming back to the other point when I was listening to your talk about the frostbite. It's interesting, because we have recently seen a couple of patients with the frostbite with this winter.
Really?
Yes, even in this region. I think one of the reason is because if you have a numbness or neuropathy due to any reason, diabetic neuropathy, or have some injury in the past or something, or carpal tunnel, which is extensive, you don't feel it.
Yeah.
Like a burn.
It could happen and you're not even aware of it.
Exactly. And I have seen the patient, even with the carpal tunnel, it's though rare that they have burned their fingers and not even feeling it.
Oh, wow.
So that's what, and the same with the feet. A lot of people has diabetic neuropathy, and even they don't have neuropathy. Some people have smoking and their sensations aren't good. And some people have just peripheral neuropathy due to what we call idiopathic. There's no reason, but they just have it. They should be very careful in the winter, because they won't feel it. And then they will end up in more losing their foot, toes, and fingers and stuff.
And that's part of the reason that you caution us, particularly if you're dealing with issues of managing diabetes, to be very careful about your footwear, about your feet, to inspect them regularly, and to be very careful about what you're stepping on in bare feet, because you may step on a Lego and not even recognize it.
Yes, and every time we meet, I try to emphasize the importance of the feet, in a sense that one thing is they are covered, so we don't sometimes pay attention, because we use them, but we don't look at them. And once they hurt or they have a problem, then we realize we need to do something. And then the problem with the feet is that what I always compare, because I'm fellowship training as a hip and knee replacement, hand and foot and ankle. So I always compare what's the difference between hand and feet. With the hand is, if I cannot use one hand, I can use other hand and still be able to do a lot of things. But if I have 2 feet, if I have to walk on 1 feet, it's reasonably difficult.
Very difficult, yes.
And the more we get older, the more difficult it is, because many people has balance problem, muscles get like not that strong. So they should pay more attention to the feet. And then usually we see like a lot of people has the feet deformities. Like they have claw toes or hammer toes and bunions and flat foot and all those to begin with. Usually they don't, like they do okay, but at certain age, once we get more older and the deformities become fixed over time, it's a progression. Then they should think about it. If they get ulcer or callus for years and it does not get better, every time they have to shave it off, I have seen so many times, then the shaver one day it get infected, and then they end up more progressive as the surgery, multiple surgeries, sometimes unfortunately losing their toes or feet, or that can happen.
And the healing process is a whole lot slower with aging process.
Yes, and then usually the circulation is little different in the feet anyway than hand. Hand has more circulation than the feet. And I think the other thing has to do with the gravity. With the feet are the lowest part of the body, so they have to, like the blood has to go up against gravity to the heart, which is less work in the upper extremities. Even most of the time we're working like this level, so it's easily go, and then it's a shorter distance versus the longer distance with the feet, and then they have persistent swelling. Swelling is kind of enemy of healing.
Okay.
So that causes more stretching and more, because swelling is a fluid. So fluid is like water. The water is non-compressible, so it's causing pressure around this healing and stretching, and even cause more pain. And so I think the healing in the foot and ankle is longer and harder than the other areas.
Dr. Cheema is our guest today from the Hays Orthopedic Institute. They're located in the Center for Health Improvement. You can park in that west parking lot through the double doors there, and he would like to talk to you about carpal tunnel issues, or perhaps foot issues that maybe you have. If you want to call now, lines are open. You'll be visiting with Dr. Gulraiz A from the Hays Orthopedic Institute, now in his 7th year, and he started out with being our guest a long time ago, and I'm glad to say he's maintaining his visitation with us, because we always learn a lot with Dr. Cheema. 625-1114 is the number to call. You want to find out more about knee or hip replacement. That's also an area of the Hays Orthopedic Institute. Or if you want to call and talk to Dr. Cheema about maybe those issues about arthritis, or some areas of concern about what you may be dealing with, reduced motion, or perhaps some areas that you need to find out about. Call the doctor now at 625-1114. And if you're outside the area, joining us on KVGB, on Eagle Community Television, on HaysPost.com, or on KAYS, call Dr. Cheema at 785-625-1114. And our first call is coming. Dr. Cheema, if you'd put the headset on so you can hear the caller. I'm going to have to reach for that. Caller, you're on the air with the doctor. Go ahead, please.
Good morning.
Good morning.
My feet, my toes at night are ice cold. I cannot get them warm, but when I feel of them, they're real warm. But their toes, and it's so strange. I've got them warm and everything, but the toes are warm, but they still are ice cold to me.
Okay, caller, if you would, turn your radio or your television down for a moment. Stay on the phone, because Dr. Cheema may want to ask some follow-up questions of you, and he can give you some help, okay?
All right, thank you.
All right, Dr. Cheema, go ahead.
Yeah, thanks for calling me. I have a couple of questions to ask you. One thing is, are you diabetic?
Yes.
And for how long?
And what?
For how long you're diabetic?
Probably 5 years.
Okay. Yeah, usually this is kind of one of the symptoms of diabetic neuropathy. And that's how the symptoms could be like, though you feel your feet are warm by touch, but sensation-wise you feel they're cold.
Yes.
And then you talked to me like you have some deformities of the toes as well?
No.
Okay. So I think that's the one reason. First thing is the diagnosis of the condition, and then diagnosis, we would like to find out one thing, if there's a treatable cause or not, which can be treated by medication or which can be treated by surgery. So the first thing I will recommend is that you should have nerve conduction and EMG studies, which we were talking about in the program earlier. That helps us to diagnose if there's a local compression. Sometimes, like a carpal tunnel, there can be a tarsal tunnel on the foot, and that can cause pressure. And the other diagnosis, which is more common in diabetics, is the peripheral neuropathy. And at least if we diagnose that, then we can recommend either you need it. First thing is the treatment of that, which is sometimes like certain vitamins like gabapentin can be prescribed by your primary care physician. And the other thing is to look at your feet and see if there's anything need to be done to prevent any further problems, including ulcers. Or that's usually starts with neuropathy. Initially you can feel them cold, but over time you will feel even numbness, and then you won't. There will be problem with the sensations. And the second thing is we like to see if you need some diabetic shoes or custom molded inserts that will help to prevent those problems from happening.
Okay, first step then would be the nerve conduction test,
yes,
which she can schedule through the Hays Orthopedic Institute, which would measure how the feet are responding.
Yes,
basically.
And the diagnosis, it will helpful in the diagnosis and what kind of, is it a neuropathy, peripheral like diabetic, or is it local pressure?
So first thing would be to call the Hays Orthopedic Institute, schedule that nerve conduction test, and then get the evaluation of it.
I think that can be done through the because it has to be ordered by a physician. So either primary care physician can order that, or she can come back. She can come and see us, and then we can look at it and then order that.
Okay, all right.
Well, my diabetes is under control. It's always good, when I take it of a morning. And but it's just a mystery why they just act like they're freezing. And
well, caller, there is
after I go to bed.
There is help available through the Hays Orthopedic Institute, or start with your primary care physician, either one.
Okay, that's what I'll do.
Thank you. We appreciate your call.
Thank you.
Thank you.
625-1114 is the number to call. You'll be talking with Dr. Cheema from the Hays Orthopedic Institute. Not an uncommon problem, I would suppose, with people managing diabetes.
Exactly. It's very common. That's why I asked the first question, what diabetes, because that's one of the common reason for having nerve problems or neurological symptoms, especially in the limbs.
Feels warm, but is actually the sensation of cold.
Yes, exactly.
That's interesting.
Yeah.
Okay. Dr. Cheema is our guest today. Call now at 625-1114 if you want to ask about arthritis conditions, or perhaps you want to ask more about diabetes management and how that might affect your health. Here's your chance to call Dr. Cheema at the Hays Orthopedic Institute, 785-625-1114. Go ahead.
The other thing I think I would like to discuss and let our community know about our joint program. Because, I am doing an anterior hip replacement, which my patients are very pleased with that.
I was going to ask you about any advances in knee and hip replacement. Talk about that.
Yeah, the anterior hip is basically from the front, and the incision is much smaller. It's like minimally invasive hip replacement. And so usually incision is between 8 to 10 centimeters, so it should be around less than 3 inches, so they're not like big incisions. And the other thing is it goes between the internervous plane, what we say, between the muscles, so there is no damage to the muscles.
Recovery is better then.
Recovery is better, and it's all patients like it. The common, like one of the complications we have noticed, one little bit of numbness on the thigh, because the nerve we have to push a little bit on the side. And generally it recovers over time. Some people may have some symptom, but overall patients are much happier there. going back home faster. Some of my patient has wanted to go the same day.
Oh, wow.
And many of those has gone next day.
Next day.
Yeah,
Wow.
it's
and is that for hips?
yes,
then?
for the hip from the front, primary hip, and we are very pleased with the results.
You've been doing that a while too,
yeah,
haven't
yes, I am doing for a while now, and so far we don't have any major complications, and as I said, patients are happier.
Further, smaller incision,
Yes.
faster recovery time, better outcomes.
Yes, and as a surgeon, I like to do what I'm doing.
Mm-hmm.
Though with the other hip, I am also trained with the hip from the side, what we say lateral, and then I'm also trained from the posterior. So I do also revision hip surgeries too, like the complicated ones are they already had surgeries, and then we have to revise them due to any reason. We do that too. So basically, our joint program, one thing is recognized nationally. Is our accredited program, and then we are also taking care of all those patients with the revision and complicated surgeries. I believe we are in this region, we are the only center who's doing the revision and complex surgery.
Wow.
Along with the primaries and
the
anterior hip.
The accreditation
Yes.
is something that is really important
Yes.
because you have been graded,
Yes.
I guess, by outside sources.
Yes,
Mm-hmm.
yes, and we recently has been recertified, and the person who came in was very pleased with our progress, and they were like amazed that how in a small town we are maintaining such a level standard of care.
Yeah, we're constantly amazed by the work that's being done at HaysMed. Okay, on this hip situation then, you evaluate the person,
Yes.
and there are some people who can use the minimally invasive,
Yes.
and others might require a little bit different based on the situation.
Yes, that's but most of the patients usually qualify through the front.
Mm-hmm.
And initially, if they have some scarring and then some like really high BMI, which we like them to decrease weight anyway, because that helps in the longevity of the replacement and has less complication.
Mm-hmm.
But majority of the patient with the primary hip, they usually qualify for from the front. So after starting with the front and the response I have seen from my patients and community, I prefer for them, all the patients, if I can do from the front. So I usually doing more and more through the front.
And to be dismissed the next day, that's phenomenal.
Yeah,
you know?
Yeah. And in the same days. A couple of my patients wanted to go home the same day, like in the evening.
Did you let them?
Technically, yes, they can.
Oh, okay.
But sometimes, another thing anesthesia-wise is that we are using also more and more spinal anesthesia. Spinal is mean like patient doesn't have to go to sleep.
Really?
Yeah, so they have spinal anesthesia, and that's easy to manage in a sense for patient, because then they're kind of awake and oriented, and then it's a recovery, like pain-wise and all those problem associated with the general are little less. Everybody has, like, general is not a bad anesthesia, but just being able to do with the spinal is more like patient-wise friendly.
So the spinal basically just deadens the area that you're going to be working rather than having to go entirely under anesthesia.
Yeah, anesthesiologists, they're very competent, and we have a good group of anesthesiologists here. And sometimes we just need to give some sedation just to relax the patient, but they quickly wake up from that. It's not like general. There's no tube involved in anything. So.
Wow.
Yeah.
That's pretty amazing.
Yeah. So if somebody doesn't have any spinal problems to begin with, or arthritis and stuff, so that kind of helps to get it.
Now, is that fairly new on the spinal?
No, the spinal is there for a long time.
Has it?
Yeah. But I think it has certain like indications, like which patient can have spinal.
Okay, gotcha. Prior to a knee or hip replacement, you're also instituting, I believe, since we've talked to some of your colleagues before, Dr. Wright, I think particularly mentioned this, that you like to have an exercise regimen ahead of the surgery so that people are better equipped to deal with the recovery.
It's a very good question. I think we have, again, through the program which we have created in HaysMed, is a pre-rehab program.
Prehab, yeah.
Prehab. So the prehab benefit of rehabilitation is that you already strengthen your muscles because as a human, generally, we can build up our muscle quick and we can lose them quick too. So, and that helps to, one thing is that it helps in the pain control, and it helps the post-op quick recovery and management. And the third thing is you are already preparing yourself for the journey. Yeah. And surgery is a small part of that journey. But after that, you are on your own kind of, the more you are involved, the more active you are beforehand, and that helps. And usually the surgery takes a few weeks anyway to schedule. We need to get medical clearance and all this workup and schedule certain days. And then meanwhile, if you're already involved in your preparation for the surgery, that helps.
Okay. Got a question, or got a call. Then I'll ask the question. Caller, you're on the air with Dr. Cheema. Go ahead, please.
Yeah, I've been diagnosed with a meniscus tear in a knee, and I was told that if it's repaired or fixed, that I might not have ability to do sports exercises again that have a lot of contact on the knee. I'd like your opinion.
Yeah, stay on the line, caller, in case Dr. Cheema would like to ask follow-up questions of you. Dr. Cheema?
Yes. Can I ask you, how young are you?
55.
Yeah, I think we are all getting in that age where you have used your knee for I'm sure you're active and you're interested in physical activities and some kind of sports activities. So, So if you don't have significant arthritis, having a meniscus tear, and coming back to the same thing, usually in this age group, it's a degenerative meniscus tear, which is not acute meniscus tear, which somebody can has in his early years, like 20s or teen years. This is a sports injury, you have a meniscus tear, everything else is good, and that tear is not a degenerative, it's just an acute injury. And that has different than if we are in 50s, because more like degenerative changes are also involved in the knee. And then it depends what kind of tear you have. If the tear is like a flap of the tear, which comes into your knee joint and it locks your knee, and then you cannot move it, that's usually where it needs to be helpful to take it out. And then the repair-wise, it's also going back to the same thing, is what kind of tear you have. It's a peripheral tear on the area where there's enough circulation or healing can happen, then it's usually amenable to repair.
So there's a certain degenerative quality that happens as we get older.
Yes. If I will have my knee MRI, or most majority of the people after, like normal folks, if they have the MRI, they will find some degenerative tears, which even they don't know.
Okay. So what's his procedure then? How should he go through this, Dr. Cheema?
Did you had an MRI?
Yes. It's being recommended to be done, but my biggest concern is not being able to do high-impact exercise or sports.
As a general, as I said, I don't have enough information to really see what kind of meniscus tear you have. Another thing is, what's the status of your remaining cartilage of your joint, like your femur and tibia, like the rest of the joint, because that will also helps to determine that how good your knee is. And that will help in the long term to decide whether you should do the contact sports or kind of those activities or not.
And the MRI will tell you that information, Dr.
Yes,
Cheema?
MRIs also, and X-rays. They complement each other and give us some information. Especially the weight-bearing X-rays. We really like to have the weight-bearing X-rays on the standing, because that gives us more information how much of the joint space is left and how the knee look like. Which
they can do in the X-ray department.
Yes.
Okay. Caller, any follow-up question?
Yeah, one last question.
Sure.
If I were to go ahead and do that and then not be able to do high-impact exercise, would it be sensible or even reasonable to try to do a full knee replacement? And if I did that, would I be able to do high-impact exercise?
I love your question. Yes, I think that's a very appropriate question. But the knee replacement, again, if what you're doing now, you should not think of doing more with the knee replacement. Generally, in principle, you should do activities like walking, a little bit of jogging, and activities and strengthening exercises. But high impact, the thing, and you're young, so it has a less chances of long-term success as a knee replacement. And as I said, before looking at your x-rays and MRI and before looking at you, it's hard to comment. But if it's just a degenerative meniscus tear, just having a knee replacement for that purpose I don't think that's probably a good option. But as I said, I need to have a whole information to give you my recommendation.
Well, I would get just one last question.
Sure.
If I go ahead with this, in your experience, do people that have meniscus surgery, are they probably never likely again to do high impact exercise?
As I said before, if there's no associated damage to the other part of the joint, chronic injuries or cartilage looks good, there's no degenerative arthritis to the other part of the knees, and the meniscus tear is very isolated, and it's like, as I said, like a flap which is getting locked in and your knee and stops your knee and hurt, and then you have to really loosen it. That probably, if that being taken, isolated problem can be taken care of, there is a chance that you can go back to your activity level which you have before. But if you have associated damage and you're 55 and then the other cartilage joint arthritis has probably started already there, then there's not that, like, it's like an aging. What you can do in 20 years age, 20, 30 years, 15 years, it's hard to do that in 55. We all know that.
What he's gently trying to tell you, caller, is that he would prefer you not go back to the high impact. Am I reading that right, Dr. Cheema?
Yeah, I think I believe more on strengthening exercises as my philosophy, and strengthening, and even static strengthening exercises. The whole goal is to build up the muscle and being active. That we can do other ways and means, not just being high impact.
Okay. Follow-up question, caller?
So my career with the NBA is over?
Hey, at 55, it was over 30 years ago, I think. Wow. That's true.
Nobody told me that yet. So.
Yeah. Now, see, these docs, they want to be as gentle as possible with you.
Well, I always had hope, but anyway, I appreciate your answering my questions.
That's a great question, caller. Thanks for checking in with us. All right. 625-1114. Sometimes the realization of this aging thing is a little tough to deal with, you know. We just have to kind of accept where we are sometimes.
I think aging is not a bad thing. It also brings its own happiness and things to cherish.
It has some advantages, believe me. Another call for Dr. Cheema. 625-1114. Caller, you're on the air with the doctor. Go ahead, please.
Yes, good morning, Dr. Cheema.
Good morning.
Keep up the good work.
Thank you.
I got just a question in general, not for myself, but for other listeners. Would you comment on replacement knees? In other words, after had knee replacements before, then the pain comes back. Would you just comment on what the situation is with replacing them again? I'll hang up and listen to them.
Okay, great question, caller. Sometimes follow-up is needed, Dr. Cheema.
Yes. For my knee replacements, what we do, our program is generally like, for example, we see the patient in the first 2 weeks after the surgery, and then we see them in 6 weeks, and then depending how they're doing, some patients I don't need to see them. They're doing so good, and they're relieved from physical therapy, and then we just see them in a year time. And then 2 years. Some patients we have to see a little more. But generally, it's then 1 year, 2 year, 3 years. So the goal is that they're different. Like if you're doing good and you're progressively healing, what can happen with your existing knee replacement over time is that it's a dead knee. One thing, like what knee we replaced was a living knee. Simple.
Oh, I see. Okay, a dead knee then.
Like it's a
That's
metal.
An interesting term.
Yeah, it's a plastic and metal.
Yeah. Okay.
So it does not have any capacity to repair. Our own existing knees, and they have some capacity to repair up to a limit until we damage them that bad that it cannot recover. Some of the aspect can recover.
Because the metal and the plastic are static, and they're not going to be doing anything in the way of healing. Okay,
so
gotcha.
it's like a car. You have a car. You take care of the car the best way you can, but it has a certain miles on it.
Mm-hmm.
And some people can get 1,000,000 miles on it. I know a guy who had like 1,000,000 miles on the Honda card, and the Honda gave him another brand new car because he had 1,000,000 miles on it.
Really?
Yes.
Oh, my goodness. 1,000,000. Oh, my goodness.
So, no, yes.
Some people are going to heal better and faster and more efficiently than others.
Yes, it's like we all different humans. As a healing process, we do the same surgery on all the patients, but still it's a little different how they respond and how their body respond. Coming back to the caller's question, the revision knee and issues with that. I think the issues, that's what we want to have them a regular follow-up, though even though they don't have any symptoms, to catch early, which is like plastic, for example. The poly and the metal, that's basic articulation. And if anything, started early loosening of the implant sometime can happen without even knowing it. Like you can see some cyst formation around the bone interface with the metal implant interface and some line certain. We usually see that. So it's just helpful, like we have one visit once a year, or then like if we do fine, you're doing fine, looks
just
good.
A checkup, basically.
Exactly. Sometimes we say, okay, we see you back in 2 years, sometime even 3 years, just depending how good they are. And then the patients who have the problem with their knees, like have a knee done and still has problems, we need to evaluate that what's the reason for the problem. Is sometime, as I said, everybody's like, sometimes they have knee contracture. They have not moved their knee much. After the surgery, because maybe certain reasons, sometimes it's painful, sometimes people has more scarring than other patients. So that's the reason. Sometimes there is some alignment issues, and sometimes again the implant becomes loose, and then the knee becomes unstable over time. Like the ligaments stretch out, or there was some loosening to begin with, and then it increased over time. So there are different factors. We really look into that.
And some pain can be caused because of these issues that occur.
Issues. There's patient-specific factors, there are implant-specific factors. So we have to really look into detail into that. And based on that, then we come up with the plan. We explain to the patients that what's going on. And obviously, it's an extensive surgery than the first surgery because there will be more scarring, and then we have to remove the existing implant and then put the new one in. And we try to also evaluate them if they have any low-grade infection, if they have done recent surgery. Or sometimes even infection can happen just from your blood, which is the most common. Like patient has a UTI or lung infection or something that suddenly can seep into the joint. So so we have to clean that, and then if they need revision, we do that too.
So there are a lot of things at play here, and what needs to be done for the caller in answering the question is, if you've had a knee replacement, and you're having some pain, get an evaluation and see what's going on.
And one of the other reasons I have seen, even the joint itself is doing good, but your patient has a tendinitis, which is they feel like their knee hurts, but basically it's not implant related. It's more of like their IT band, which is tight. And their hamstrings are tight because the reason is with arthritis, they lose their joint space over time. And so once we do the knee replacement, it's like a replacement when you were in teen years. We create that joint space. That's the whole principle of knee replacement.
Like you were back in your teen years.
So it means if you have a deformity, like the legs were little like intoeing, and so it deformed. Now it's straight straight leg. And so it means we have to cut the cuts. So we take the minimum bone from the bad side, and we have to take the little more bone on the other side to match it, and then create a straight, like better lined leg and correct the deformity. So sometimes that leads to stretching of the soft tissues, which those tissues are not used to. And patients have the pain and problem, but that's not per se arising out of the implant. It's more of their tendons and capsule and soft tissues. So that's why we need to see different factors and what's going on. And if we can see them in the office, sure, we can take
it. All works together, but it's not necessarily directly connected with the tendon situation.
Yes, exactly.
Wow. Okay. We have time for maybe one quick question. If you were thinking about one, you want to ask Dr. Cheema, here's your chance. 625-1114 is the number to call. We have time for one quick question here on Health Information Please on KAYS, KVGB, Eagle Community Television, HaysPost.com, the iTunes and Google Play app at 94.3 KAYS, and now on Facebook at 14 KAYS. Real quick, if somebody wants to call, now's a good time to do so. But back to the carpal tunnel where we really started. Way to prevent it? Or are we just doomed with some repetitive situations that we find for job or work or whatever we're doing?
I think, yes, there are a couple of things to look into. One thing is, obviously, if it's related to your nature of the work, use of your hands, then if you can modify the activities, if possible, in the ideal circumstances, that's good. That's taking the causative factor away. And if you can, due to your circumstances, then there, like, just to be aware of that when symptoms starts. Another thing is sometimes you can use the splints, like the night splints we have for the patients as a treatment. And then there's like physical therapy can teach them sometimes the nerve gliding exercise, what we say. So that sometimes can help. And sometimes we can use the injections in the carpal tunnel.
Oh, okay.
Yeah. So there are different modalities available. And but as I said, it's usually the surgery is simple, and you don't want to go to that wait that long when there's a permanent damage in your nerve. That's
something that I think bears repeating that you mentioned earlier in the program that I want to make sure that we focus in on, and that's if you're experiencing a tingling, a nerve sensation, a numbness, etc., get it looked at early rather than putting it off or waiting, because the fix is easier the sooner, right? Is that fair?
Yes. And especially if it affects your activities and affects your work, and sometimes you're concerned they're going to drop your things, or you're putting your hand on the steering wheel and it goes numb. So it affects your fine dexterity.
That's an important point to consider, too. Okay, Dr. Gulraiz Cheema, our guest today on Health Information Please.